Good evening, everyone. My name is Kellen Penny. I am the administrator of the Jackson Multi-Specialty Clinic here in Montgomery, Alabama. I just want to make a few points prior to starting the meeting and turning it over to our speakers. Number one, this meeting is being recorded, so I want everybody to be aware of that. I would like everybody to stay on mute throughout the call to allow the panelists to speak without interruption. There's also a chat option at the bottom of the screen, so please feel free to type any questions that you have into that chat box, and we'll make sure to answer your questions at the end of the meeting. And last, just remember that all of the phone numbers we give out during this meeting, we're going to make sure that we post those in writing when we send out the recording of the video. Tonight, we have 3 panelists available to speak with you about how we can work together to keep COVID patients out of the hospital. We have Dr. David Thrasher, who is a pulmonologist here in Montgomery, Alabama. Dr. Michael Sagg, an infectious disease specialist from UAB. Tommy Cobb is a pharmacist and the assistant vice president of pharmacy services here at Jackson Hospital. So at this time, I was either going to turn it over to Dr. Thrasher or wait a couple more minutes for some people to join.
Okay, Kellen, thank you. Why don't we just wait a couple more minutes, and what I will do is just talk briefly, because I want as many people to hear what we're going to do as possible. Am I on now, Kellen?
Your video is not on. Let me turn you on.
All right.
There you are.
Okay. It's probably better with it off. All right. Well, I'll go ahead and start. Just some basic things that you probably know. We're into this pandemic probably about 19 months now, and last year when we had the first monoclonal antibody release for emergency use, here's Mike Zag. Good. Okay. That was a game changer. The first one was Eli Lilly bamlanivimab, and then we got Regeneron. Then we had the vaccine that was announced by Pfizer in early November. And I said, that is a game changer. Everybody was asking me, when is this going to be over? I said, well, once the vaccine is available, that's when we'll know when it will be over. And I predicted then that we'd have Independence Day. And this past July 4th, I was feeling pretty darn smart. Said, boy, I'm right on the prediction. And what I did not predict is there'd be so much vaccine hesitancy. And that's what we're seeing now. And that's what we're seeing really the surge of the Delta variant. The Delta variant now is probably north of 90% of all the cases that we're seeing in Alabama and probably throughout the United States. Now, this virus this variant is about 1,000 times more infectious than the other ones, and that's what's caused us trouble. I said before, this is going to go through Alabama like Sherman did Georgia. It's going to be hard, fast, and take no prisoners. I truly believe, unless the Lambda or another variant comes forward, that this may be the last surge we have. I hope and pray that I'm right on that prediction. But it is going to be hard and fast. It's already overwhelming Alabama's hospitals and emergency rooms. For the last several days, from Mobile to UAB, and I'm not sure about North Alabama, it's probably the same, almost every single emergency room was on diversion. Now, what that meant, if you're in a car wreck, you're in a world of hurt. If you had an emergency situation where you need to call an ambulance, you were in a world of hurt. That's what we're talking about tonight, and that's why we're here. Now, we have the Regeneron's vice president is on this call too, and I've talked to him, and they are great. I can tell you right now, they have assured me and Scott Harris with the Department of Public Health that they're on our team. They're not going to let us give out of a product, and they're on our side. And this is an amazing monoclonal antibody that Regeneron has established. If you remember this is the one that President Trump got. But more important than President Trump, we are now infusing literally hundreds and thousands of people. We're keeping them out of the hospital. Now, before I turn to Mike Zag in just a second, I've got just some data from a local hospital, not Jackson, not Baptist, just a local hospital. And Mike may have some current data on UAB, but just what happened with the monoclonal infusions. Well, in a 1 month period, if you had the monoclonal antibody, your chance of hospitalization was 7%. If you did not, it was 39%. If you had the monoclonal antibody, your chance of going to the ER was 20%. If you did not have the infusion, it was 65%. More importantly, the mortality on monoclonals was 0.9% in this study versus 8%, a big change. This is the one thing we have, and you guys, most of you guys are primary care doctors on this call that I know of right now, but we want to get the emergency rooms, we want to get urgent care, we want to get the OB doctors, we want everybody on board because this is a great product. And basically, people ask me, well, who can qualify for this? I'd say if you are in Alabama, you probably qualify. It's almost everybody qualifies. Basically, we'll go over the criteria and we'll post the criteria later. But basically, if you have a BMI greater than 25, and there's probably not anybody in the hospital that doesn't have that, plus hypertension, lung trouble, it's very, very broad, okay? Including pregnancy. I want to make sure that everybody knows that. We're infusing 2 pregnant women a day. We intubated 1 pregnant woman today. We did 2 C-sections, we being the OB, obviously not me. My point being is OB people are getting sick with COVID. I want to welcome Mike Zag. Mike and I have been kind of joined at the hip since last February, if you would, before the virus even hit Alabama. And we've teamed up and help us start some infusion centers really all over Alabama back last November, December, and January. And he's a great guy. He's an infectious disease doctor. He may be the only ID doctor that I know that had COVID and is an expert in COVID. So Mike, if you would tell us a little bit what you're seeing at UAB and tell me your experience with the monoclonals with Regeneron and what you think we should do.
Sure, thanks. And hello, everybody. I think we're in the worst of this. We thought we had it bad in January. Labor Day is going to be 2 to 3 times worse. We're already kind of where we were in January, at least in terms of numbers of cases. Not as quite as many in the hospital, but as David just said, the ERs are getting overwhelmed right now. So if you look at Louisiana, that's probably where we're going to be in about 2 weeks. And Louisiana, they're running out of ICU beds and they are really overwhelmed. They're having to have trauma patients go elsewhere. The difference between Delta and the original virus that we saw is mostly young people getting sicker. Fortunately, most of the older folks have been vaccinated, and the vaccines work about 80% in terms of preventing infection and 95% in terms of preventing hospitalizations and 99% in terms of preventing death. There's no question that this current spike, I'm not going to call it a surge, the spike in cases that we're going through right now is a spike of unvaccinated people for the most part. So what do we do about it? The first thing I would say is let's review some biology. COVID as a disease is a biphasic illness. The first phase is the first 6 days after onset of symptoms, and that's kind of the viremic phase, where the virus is replicating at high levels, and the immune system, mostly it's an innate immune response that is based on interferon mostly. And then after that 6 days in, the adaptive immune response kicks in, think antibody, other T cells, and that's what kind of mops up after the innate immune response has knocked the virus down. What we know is that somebody who's vaccinated, they can still get symptomatic and they can still get a spike in virus acutely, but it comes down very fast. And part of the reason for that is that the immune system is primed, there's antibody around, and more gets produced very quickly, and that takes it down. For the unvaccinated people, that won't kick in until day 10 to 14. So when you give a monoclonal antibody, you're basically giving them that result of the adaptive immune response. It's in essence passive immunity that you're administering on hopefully early, day 2 to 3 to 4 after onset of symptoms, and it can really attack the virus and knock down the viral load so that longitudinally there won't be any symptoms. The worst thing we can do, this is if you pick up nothing else this entire call, the worst thing we can do as doctors is prescribe systemic steroids in the first 6 days of illness after onset of symptoms, because that interferes with the innate immune response. It allows the virus to persist for a longer period of time, and that leads to more prolonged illness and much worse outcomes. So the virus, like in almost every viral disease, the virus is the enemy, and it's what we really want to control. The monoclonal antibodies knock that down and shorten the course of illness when we use it. Could we use it antiviral in that stage? Sure. I mean, we could use remdesivir, certainly hypothetically, but it's a 5-day infusion daily, and it's just impractical for outpatients. They're working on oral therapies, think like a Tamiflu for COVID, but it's not ready for prime time. It hasn't been proven to really work. So that's kind of what we've got. Both the Lilly product and the Regeneron product worked really well against the original virus and against the Alpha variant. The Lilly product does not work against the Delta. The Regeneron does. The SmithKline or the GlaxoSmithKline antibody does, but it's not quite as readily available to us. It's only one antibody. The Regeneron has 2 antibodies, as does the Lilly product. So maybe we can, what we're seeing in terms of numbers, we're going through the spike like everybody else. We're now infusing 16 people a day, maybe up to 18 a day, 5 days a week here. In the surge that we had in January of 21, we opened up on weekends as well. Something tells me we're going to be doing that again. The thing that keeps me up at night is 2 major things right now. The first is that the spike we know is going to hit us, and it will be hitting a peak around Labor Day. So we haven't seen nothing yet. The thing that keeps me up is that all the modeling shows that that spike comes up and then it's going to go down. And that's based on what was seen in India and what was seen in Great Britain with the Delta variant. Here's the problem. Both India and the UK had mitigation that people bought into. Universal mask wearing everywhere, lockdowns, which we are intolerant of in the United States right now. And in the UK, 80 to 85% of people were vaccinated, and that got them out of this. In India, they went to more very aggressive, almost draconian mitigation strategies, which the US population has zero ability to comply with. So whether we're going to go up and come down like they did, or whether worse, we're going to go up and plateau. And we aren't going to know that until mid-September. So that's the first thing I'm worried about. The second thing is a corollary of that. We want our kids back in school, and they should be back in school. But in my view, you can't just send them back to school and into harm's way without protection. So sending kids back into the classroom, especially less than 12 years of age, when there's no vaccine available for them right now, and not requiring masks in every classroom is going to be a disaster. So what will happen is, with the rates of infection that we have right now in our state, the chance that 1 person out of 30 in the classroom is going to be infected at that moment in time is about 50 to 70%, that 1 out of 30 in any classroom right now. And by first part of the September, that's going to be even higher. So you can already see what's going to happen. A child will test positive. the entire class by rights, by decree, should be quarantined at that point because they've been in a small space together for 8 hours. Not wearing masks is going to make it even worse. So by mid-September, a lot of the schools are going to have a large portion of the students staying at home. And the best way we can prevent that is to have the kids wearing masks. And a lot of the school systems in Birmingham are now going to that because they got the message. Why we're so anti-mask, I have no idea. I could argue it's politics, but it doesn't make any sense. No politician, in my view, wants their populace to get sick and die potentially. That doesn't add up. So we need to be smart about this at this point. But I guess the crepe that I'm laying here is that we're in for a big problem over the next 3 to 4 weeks. And whether we come out of it quickly or not, only time will tell and our behavior will tell. Finally, encourage every single one of your staff members to be vaccinated. All of us should be vaccinated. If you're not already, get vaccinated, set the example, and then get everyone in your community as fast as possible to get a vaccine. It is the only way out of this. This vaccine works, as you've just heard, but also it's safe. It's at least as safe as any vaccine we have, probably safer than the influenza vaccine and much more effective. So now's the time to get people vaccinated, if not yesterday.
Thanks, Mike. I agree 100% with that. And that's kind of where that's where the state of the state is right now. Now, what could you guys do that are on this call? Well, Dr. Handy, I saw one of your patients. I saw. I've not seen maybe 2% of the 2,500 patients I have infused in this year. I do this mostly on the phone, but George, I called one of your patients actually over the weekend. We got him infused. Now, Baptist and Jackson are expanding their infusion capacities the best they can. I understand we're limited from staff. I get it. The resources are tough. Talked to Mobile Infirmary earlier this week, 174 their staff people were out sick with COVID. Like Mike said, it's going to get worse. I've seen predictions of the unemployment may go up to 20% in the next 60 days because people staying home with their sick kids, just like Dr. Sachs said. What can you guys do? You can save the emergency rooms, and by saving the emergency room, you can save the hospitals, you can save the elective surgery, which is the money cow, if you will, of the hospitals. Now, when these people, instead of letting them go to the emergency rooms, or worse, going to the urgent cares, which still have not gotten the memo that we don't give steroids the first 7 days. If one of your patients gets it, we'll post numbers. It's real simple. You could call in verbally the order, or you can fill out the sheet. It'll go straight to them, and they'll set them up on the infusion. The key is we got to get them in by 10 days from symptoms. That's the key. And I've talked to Joe Riley and the powers to be at Jackson, and we're going to expand the capability as fast as we can. Baptist this weekend went to 7 days a week. I think that's what we're going to have to do. You know, Delta doesn't take the weekend off, and frankly, neither are we going to be able to do that for a while. So we want you to know the criteria, which is very simple. Basically, if you're alive in Alabama, you go just about qualify. I'm not going to talk too much about exposure right now because, frankly, let me back up. If someone is exposed to someone with a virus, they are potentially a candidate for infusion, even without a positive test. I don't want to go there right now because we simply can't handle it. If you'll be diligent with those people, and if they start showing symptoms, get a quick test or go straight to the infusion at that point. But this is going to take every one of the clinic doctors to call on their patients, tell the patients, if you got COVID, call me being you, and tell them how to get infused. Well, what do we do? One of the doctors in Greenville said, what do you do afterwards? Mike and I have talked several times about this. I started off trying everything from zinc to the vitamins to vitamin D, everything. Excuse me, I'm on call. Let me try to turn this thing off. What I do now is simply, if they're not on anticoagulant, I give them a full dose aspirin, 325 a day, in hopes that it may help with the clotting issues that we see. I am seeing the younger people have clots more than I did the older people last winter. I'm also giving, I've been doing this for a long time, budesonide, 0.5 BID and a nebulizer. I tell them just do it for a month. There are some studies that show that it does to help decrease the hospitalization. It makes them feel better, and I think it helps a little bit. That's about it. You can give vitamin D. I used to drown people in vitamin D. That's I can tell you the studies just do not support that it really works. Zinc doesn't work. There's zero reason you need to put people on antibiotics when only 1% of people with COVID-19 have a bacterial infection. So that's about what I do. Mike, you want to talk a little bit about that if you disagree or that or anything other tricks of trade that you have after the infusion?
No, I think people tend to do very well. One of the things we're struggling with a little bit right now are the people who are vaccinated and have breakthrough infection. Up to this point in time, we've been using the same rules for unvaccinated and vaccinated people, but I'm noticing, especially if some people are a little bit delayed in getting to the infusion center, if they're vaccinated, that by the time they get there, they're feeling much better. And I'm wondering whether if we start with this onslaught, we really need to triage up to the top the people who are unvaccinated, because they're the ones who are going to have the most clinical benefits, since they're the ones most at risk for going to the hospital and certainly the most at risk for death. The exception for sure would be any vaccinated individual who's immunocompromised, who's a transplant person, who's on chemotherapy, who's on an immune modulator for inflammatory bowel disease, arthritis, and that type of thing. I will give with this bit of data if you need more ammunition to convince people to get vaccinated. In May of this year in the United States, there were 18,000 deaths from COVID. 17,850 of those deaths were unvaccinated people. In June, 10,000 deaths, same story. 99.2% of the deaths were unvaccinated, and that's continuing onward. History will look back at this and say, just what everyone will scratch their head, like, what was wrong with these people? They had a vaccine. Yeah, initially we didn't have enough supply. That changed in April. And all of a sudden, those who wanted to be vaccinated were all taken care of. And it was only about 45% of the country. And everybody else just didn't go. And you're kind of like, what is wrong? Why aren't these people getting vaccinated? In about a week or two, the FDA will give full approval. I can tell you the data I was quoting you earlier about the safety is coming from the data that's being submitted to the FDA. This vaccine is remarkably safe. From all the data that we have, hundreds of millions of people, actually 2 billion people worldwide, we are not seeing anything unusual or untoward. In fact, the opposite. The 40,000 patient studies that were done back originally that were incredibly well performed, all that information on safety has borne out. So we're in the middle of a hurricane, and people still are refusing to leave their homes and come inland. They just want to weather the storm. It's not going to turn out well for them.
You're exactly right. And Dr. Aruna Arora, he's the president of the Medical Association of the State of Alabama, has produced weekly webinars. If you go on Facebook and go to Medical Association of the State of Alabama, push videos, you'll see the first one, Mike and I talked about Delta. The next one was the head of infectious disease. I believe that's his title, Mike, at Children's Hospital, which gave a great discourse on masks, children in school, vaccination, children, myocarditis, et cetera. And last week we had one of the head OB physicians at South Alabama talk about the myths of pregnancy and vaccination. Basically, does not cause infertility, does not cause increased miscarriages, and does not cause trouble with pregnancy. What she said and what we're seeing a lot right now is a lot of pregnant women getting COVID and not doing well. We've had a couple of urgent C-sections just this last few days here that we're taking care of pregnant women with COVID. And so you don't want to become pregnant and get COVID. So pregnant women can safely be vaccinated. That's been shown, and that's the position of the Academy, the OB Academy. So I guess we'll start, Kellen, open up for some questions, but the one thing I want to tell you guys on this call, you will be the ones that make a difference. Dr. Sagan and I are doing all we can do. You can certainly order the infusions. It's not hard. It's safe. Regeneron has got a great product. If you have questions about it, y'all got my cell phone. You can call me. If I can't answer it and Mike can't answer it, we'll go straight to the CEO of Regeneron, who's been great to help us. Mike, you want to have any question for Kellen? You want to see if there's any questions?
We do have some questions. So I have a physician that's getting questions about revaccination and getting antibody levels done in patients who had early vaccination. What should be our approach to that question?
I'm going to let Mike answer that. He is an expert on vaccination. He's been working on this his entire career. I actually just did an article this past weekend on boosters, and I'm going to turn it over to Mike to finish up that response.
Yeah. So they're really, the tests for antibody are not reliable enough, in my opinion, and we don't know quite what to do with the data. So I don't advise getting an antibody level. What we do know is that right now, if there's a patient who's immunocompromised, we are recommending a third shot right now. So that's cancer, all the people I mentioned earlier, in terms of cancer chemotherapy, immune modulators, those people who are transplant recipients. So they should be getting their third shot now. For the rest of us, I'd hold tight for a little bit longer. The immunity is working, and we know that just from the empiric evidence that we've already quoted about the people, yeah, you can get a breakthrough infection. It's not all that common. There's a lot of exposures to where vaccinated people are in a room and don't pick it up. So again, the vaccine's 80% effective. But where it's really, really working and where we need it to work is in preventing the hospitalizations and preventing the deaths. And that's still the case. All that said, my bet is that within the next 2 months, maybe 3 months, we will be vaccinating most people with a third shot. But rather than focusing too much on that right now, I'd like to get everybody to get their first series right now. And that's what we would want to do.
Yeah, I agree 100%, Mike. And Mike mentioned this earlier, but I want to say it again. One of the most unfortunate groups of people are those with inflammatory bowel disease, Crohn's, ulcerative colitis. Now, they do not do well with their first couple of shots. And like Mike said, they qualify, in my opinion, and the FDA will probably say this week, that they need a third shot, pronto. Kellen?
Is there any guidance for people who get COVID in between their first and second vaccination?
Well, there have been probably 1 million people that has happened to. Same thing is that some of them have the first shot and then get pregnant. Basically, if they've had a shot, they get the virus and they qualify, which most people will, I'd go ahead and give them Regeneron infusion, and then I'd wait 90 days to give the second shot. Mike, you agree?
Yeah, that's right. Well, the 90-day thing is changing a little bit. More and more, I think the data is coming out that we could shorten that time.
Right.
So maybe 30 days. But the point is that you're right. I can't tell you the number of people who come in for monoclonal antibody who got their first shot 10 days before they got sick. And it just isn't enough time for the first shot to kick in. The first shot starts to kick in with immunity, and where you can start actually to see the separation of the curves from the phase 3 study at about 12 to 14 days, and then it just keeps getting better from there. So I'd say by the second week, there's beginning of a reasonable immune response even before the second shot. But for Delta, both shots of Pfizer and Moderna are really needed to get the most robust protection.
I'll go ahead and ask you one question, Mike. A lot of people have asked me, and I've read some data on this. If you had the J&J shot, which we know is not quite as good as the messenger RNA vaccines, would you recommend a booster now?
Not really. The J&J is still holding up pretty well. You're right. It's not quite as good, but it's darn good. And
Yep.
It's certainly performing better than any influenza shot we've ever used. So I think it's fine. At the end of the day, again, I think we're going to find that it'll be okay to go from a single J&J when the third shot, if you will, for Pfizer and Moderna recommended. I think they'll just line people up who had J&J and put them in the queue. I know there are people working on the data, but I don't have any definitive answer for that.
Okay, thanks. Kevin?
So I have a question. If you've seen any studies comparing previous infection or natural immunity versus vaccination?
Yeah, so the natural infection does protect to a degree. The problem with it is it's not nearly as broad in terms of picking up other variants, nor is it durable. So we're recommending everyone get the vaccine after they've had natural infection. It just will get, especially for Delta, it will give a lot more protection. So I can give you data on me as an N of one. I was infected in March of 2020, had a pretty tough go. I didn't have to go in the hospital, but came damn close to having to be admitted. After the 14-day illness, I recovered and went back to work and started working in the COVID clinic. December 22nd, I got my Pfizer shot, had a very profound reaction to it. Along the way, I was participating in research, and my antibody neutralizing, not just measuring clinical, but neutralizing antibody went through the roof, like at 45,000 units, and it was broad. It not only got every variant for SARS-CoV-2, I actually had immunity that developed that wasn't there before for SARS-CoV-1, the original virus. So that's how profound and robust the immune response is. So people who have had prior COVID and then get vaccinated have the best immunity of anybody.
Yeah, I agree 100%. And why I mentioned the 90 days after the infusion, if you do not get infused and you just say you've had one shot, get the virus, we used to say wait 90 days. Now that is not needed now. Mike, I tell them after they recover, maybe a week or so and are feeling okay to go ahead and get that second shot. You agree?
Yeah.
All right, Kellen?
So the next question that I have is, would it be beneficial to cross over from Moderna to Pfizer? This provider has read a study that it may be more effective than a booster.
Don't know yet.
Okay.
Right now, we're recommending for the third shot for the immunocompromised to get the same. You know, I could argue with equal intensity each side of the discussion to get the same or get different. At the end of the day, I don't think it's going to matter. But right now, the recommendation for those who are immunocompromised to try to get lined up with whatever was given before.
For immunocompromised patients, should the period between the second and third dose, should that also be 3 to 4 weeks or something different?
I don't know the answer to that, David. Do you? I mean, I think 3 to 4 weeks makes sense.
Yeah, I actually saw that this weekend, and most people are saying wait 4 weeks, and that makes sense. So I'm telling people four weeks. But to be honest with you, most of the people have been vaccinated a long time ago, so they're
Right. That's why I kind of shrugged.
yeah.
Another question is, what is being suggested for patients asking about ivermectin, Plaquenil, and phenobarbital? Sorry.
I'll let Mike talk about that. If we've been asked that one time, we've been asked it a million times. I'll just tell you my experience, and I want to turn over to the expert. I said in December when Mike and I made our first video, I don't know. I don't know the data. Nobody would hope that this worked any more than I did or Mike did. We started using it several months ago, a lot in the hospitals. I used it at a Baptist hospital, and my group did, and Jackson. The hospital stopped when Merck said basically it's dangerous, it doesn't work. We went back and looked at our data, and we show no improvement. I can't tell you how many people I have treated, patients who are on this call that had patients on ivermectin, got very, very sick. My partner took it prophylactically. He got COVID. There was a study that the only study that came out that looked a little bit promising. It was fraudulent study. I'm going to turn over to Mike, who's an expert on this.
Just to break it down, hydroxychloroquine has had numerous studies. It bottom line doesn't work. And if you want empiric evidence of that, President Trump had sort of touted that, but when he got sick with COVID, he didn't get hydroxychloroquine. He got Regeneron antibody, he got remdesivir, and he got corticosteroids. So he did not take hydroxychloroquine. It doesn't work. Full stop. For ivermectin, there have been meta-analyses that hinted that it has activity. One of the meta-analyses had that large study that was later retracted. You take that out of the equation, there's really no significant effect. And to me, the commentary from Merck says it all, that this is a drug they make. If they sold it, they would make money. They tell people not to use it because it doesn't work and it's unsafe in the setting of COVID. I don't know what more information we would need than the manufacturing company telling us not to use it. And as far as fenofibrate, that's brand new information, just came out about a week ago, where there was some in vitro studies where fenofibrate showed activity in the test tube against SARS-CoV-2. I've done HIV work for almost 4 decades. I can't tell you the number of studies where I saw antiviral activity in the test tube that didn't translate into humans. So maybe it will, but right now there's been no clinical trial. And until we have clinical data, it would be wrong to use that medicine, in my opinion, especially when there are options out there like a monoclonal antibody for those eligible. And then I'd stick with the inhaled steroids and the regimens that David reviewed for you earlier. This is not the time to sort of start throwing the kitchen sink at people, especially when it can theoretically, if not actually, make people worse.
I agree 100%. Again, to me, the debate over ivermectin and hydroxychloroquine is over. We have got a drug that works. It's called Regeneron. Guys, use that. Use it early. Use it quick, and it will work. It keeps you out of the hospital. Back to ivermectin, one of the things everybody is touted is a safe with no problems. Well, you better not be on some blood thinners. And I've had several people come in that took too much of it and had significant liver damage. So, let's stick with things we know is working, and that's Regeneron monoclonal infusion. Kellen?
So the next question is, are they redefining close contact exposure since the Delta variant is more infectious? For example, it used to be within 6 feet for 15 minutes. Has that changed?
Not to my knowledge, but I think that you could argue that it could and should. The problem is now we've got such a mixed bag, right? We've got people who are vaccinated, people who are unvaccinated. What I can tell you is that among unvaccinated people, if the Delta variant enters the house, almost everybody in the house is assured to be infected. It's darn near impossible to prevent that. And we're seeing members of families coming in sick all at once or within days of each other. And that there's not much we can do about that. As far as close contacts for vaccinated people, that's where things have changed. We had said, don't worry about it. Now we're saying with Delta that the folks, if they've had a close contact, like what was just described, that they should quarantine for just a few days and then get tested on day 4 or 5. If that test is negative, they can come back out. But Delta is a different animal the data that came out of Provincetown and also some studies out of Singapore are showing that it can be transmitted person to person from a vaccinated to another vaccinated person. But like I said earlier, the peak viremia can be high for a very short period of time, and then it comes down because of the vaccine, and that's where the real benefit is.
Now, Mike brought a good point about when to test these people. Typically, we say 5 days. Probably right now, data shows that you're going to test positive quicker. So, if I'd say about day 4. Now, Mike, a tough question, and I've struggled with this too. I'm vaccinated. My wife's vaccinated. I come down with the virus. I'm asymptomatic or have the sniffles. My wife is asymptomatic totally. Now, do we keep her home for 4 days and test her, or do we let her go out with a mask before that?
I would try to stay home because we don't know whether she would be infected or not. But if she does go out, absolutely she should be wearing a mask and avoiding any kind of crowded area, just for the sake of not infecting somebody else. Nobody wants to be that person.
Sure. And guys, Mike and I did a video 3 weeks ago trying to urge the urgent care of people. When somebody comes in with sniffles, it's okay to ask if they're vaccinated, but then treat them as if they weren't. Test them, because we're getting so many surprises. Just this last weekend, I had a outbreak in a choir in a church here with nine members. I got called not too long ago, 20 people in a series of rural churches having a reunion. My own church, I'm treating 6 people right now. So it's very contagious, and most of the ones I'm just describing to you are vaccinated people. Kellen?
Do you see any new good therapeutics coming on board in the next few weeks or months?
Not in the few weeks, but maybe in a couple, 3 months, maybe 4 months if we're lucky. Merck has a couple of cytidine analog drugs that are similar to what we used to use in HIV nucleosides, and they're testing it. Well, I don't know data yet. I mean, the preliminary data shows good PK and all that, but we need the phase 3 studies, and those data just aren't out yet.
Okay.
Next question. I've heard the term super spreader related to vaccinated people. Could you elaborate on this?
Oh boy. Yeah, I think that's in reference to the Provincetown event, where there was a large number of people who became infected. 74% or so of those folks were vaccinated, which was the shock, was a surprise. And that's what Delta did. None of those people died. I think there was only a few, like 6 or 7, who ended up getting hospitalized. And among the unvaccinated people, that's where the damage was mostly done. So super spreader basically means an event where there's a lot of infection that gets transmitted. Almost always the major super spreader events are among unvaccinated people. But it can happen, as we saw with Provincetown, among vaccinated folks. But again, that's why we're saying I would avoid large crowds. I would avoid church unless it required everyone who's there to be vaccinated, and then we space people out and everyone wears a mask throughout the entire service. Choirs need to be spaced out. It's hard to sing with a mask, but if the people aren't vaccinated, you're just asking for trouble. And this Delta is not messing around. It's quick. It hits hard. It's a very dangerous variant, and it's changed everything that we thought we understood about the virus on almost every level because of its potency and its ease of transmission.
Yeah, and one of the points that Mike's speaking about our churches, and that's so controversial. I can tell you a lot about that. But you got to remember the 3 main sparks of super spread events are religious ceremonies, meat packing plants, and call centers. Well, we don't have to worry about the latter two too much here, but our churches, our synagogues, be leaders and talk to your pastors and rabbis about that. Kellen?
Are you seeing children with serious illness from COVID? And if you see them in the clinic, are you recommended any treatment or just quarantine?
Yeah, that's also what's different about Delta, and the program that David referred to earlier with Dr. Kimmerling, that showed that I think there are now 32 patients in Children's Hospital right now in Birmingham, and about 6, 7 in the ICU. So these children range in age, but there's 11-month-old that was admitted with COVID pneumonia. There are some kids who are under 12, some who are adolescent. The fact, and the ER is getting clobbered with outpatient stuff. Right now, the monoclonals, to my knowledge, still are not approved with early use authorization for children. I could see how it could work, but I wouldn't administer it without data or approval. Otherwise, we're just sort of left with the same rules that we have for adults, where you're going to treat them outpatient, try to keep them out of the hospital. If they do get admitted, then they're getting remdesivir and steroids and that type of thing is what I understand. I'm not a pediatrician, so I don't know details.
Kellen?
So I think that concludes all the questions, unless I don't see any more coming in.
I'm going to, before Mike and I close, Tommy Cobb's on here. Tommy has been an unbelievable resource throughout this pandemic. Tommy, do you have any comments?
Yes, sir, I do. I just wanted to let all of our providers know that are on the call that we have updated our MAB infusion protocol. Kellen, I was going to ask her to get that emailed out to everybody. It'll be posted on the intranet tomorrow. So if you need to download it, you can send it to us. We're increasing capacity. Our infusion staff is working hard to get our old infusion area back up and running and to get it staffed as quickly as possible to try to accommodate all the patients that we predict we'll be having. We did edit, as I said, and we removed the Lilly product off of order set for obvious reasons. I would caution everybody on the post-exposure. We know we'll probably have some case-by-case basis, but until we get to the point where we can meet the demand for those that are actually COVID positive, we'll have to carefully scrutinize any of the post-exposure prophylaxis that we infuse. We're working to try to find additional locations to infuse patients so we can further increase the capacity, at least up into the allocation that we were currently receiving of the Regeneron product. With regards to vaccines, again, we have vaccines almost every day at the Jackson Apothecary. We have not worked out a process yet. I know Dr. Thrasher and I have talked several times about booster shots and how we're going to manage that. But we want to fill that capacity up first, and then we'll be looking at what other alternates we need to provide for our employees and also for our patients. I don't have anything other than that, Dr. Thrasher. If there's any questions for me, I'd be glad to answer them.
Okay, thank you so much, Tommy. Again, for you providers on the call, if you have any technical questions, Tommy's your guy. He's been an unbelievable source for us. I've reached out to him and so many of these people in the middle of the night, whatever. So we're very fortunate to have a really strong team. But you guys on the call are the team now. I know we got Greenville and Andalusia people on this call too. We're trying to help them. This is a situation where we can't have people be transferred to UAB or to Montgomery to get infused. Okay, we got to have every mom and pop place in America able to do this. Now we have some limitations because the governor's pulled our emergency authorization situation, which makes it easier to do. And we're in robust talks with the governor, but being honest with you, I don't think that's going to change, because she's under a lot of pressure from the anti-vaxxers, et cetera, but she's doing a great job, trying to do the right thing for us. Now, I'm going to close. I'll let Mike close it out. But first of all, I want to thank Mike Sagg so much. He's we've been doing this since December, and he's a great human being, a great resource. And we're very fortunate in Alabama to have a source like Mike Sagg, who never, every time I ask him, he never hesitates. He worked the clinic into 5:29 tonight. Okay, but come on and help us. And Mike, thank you so much. And I'll let you close us out.
Well, thanks, David, and you, but everybody, you especially, though, have been a stalwart in this. But all of us are being called into a tour of duty in a war right now, whether we like it or not. And the analogy I make is that this is our third tour of duty going into a war zone. And I think we're all, the COVID is very disruptive, but it's also very exhausting. And unfortunately, it's going to get worse over the next 4 weeks. So brace yourself, take care of yourself, support one another, just like as if we were in the military in the trenches together, because that's exactly what this is like. And we've got to take care of each other. But as I said in a Washington Post editorial about a week ago, we're fighting a two-front war. The war against the virus is formidable enough, but we're also fighting against a lot of misinformation and just outright hatefulness among some quarters. And as if this wasn't bad enough, we've got to put up with that. And that's making our jobs a whole lot more difficult.
Amen. Kellen, do you have anything else you want to close us out?
Yeah, I just wanted to say thanks to everybody, and thanks to Dr. Thrasher, Dr. Sagg, Tommy Cobb for joining us and providing this education. Y'all have a good night.
And you'll post this with some phone numbers, some things you can give them my cell. The whole world knows my cell number by now. I'm available pretty much 24/7 for any questions I can help you. I'm more than willing to do it.
Thank you.